Welcome to the deep dive, where we try to cut through the complexity to get to what really matters. Today, we're tackling a topic that impacts millions in diabetic foot. Now, it's often linked with pretty serious outcomes like limb loss, but here's the key thing. You actually have a lot of power here.
That's exactly right. I mean, think about it. Diabetes affects hundreds of millions globally, and it leads to over 1 million amputations every single year. That's roughly one every 20 seconds. It's staggering.
Every 20 seconds, wow.
But here's the twist, maybe the hopeful part. A huge 80% of these amputations start with a foot ulcer. So that number, 80%, it's not just scary. It shows there's this massive opportunity for, prevention and good management.
Okay, so that's our mission today then, to empower you, maybe you're a patient, maybe a caregiver, with clear insights, stuff you can actually use. We want to help you understand things better so you can, more informed chats with your healthcare team. Turn that anxiety into understanding. So where do we start? What are those foundational steps for prevention?
Well, first off, regular checkups. They're absolutely key.
Yeah.
If you have diabetes, you really should get an annual foot inspection, a proper one, by a doctor or a trained foot care provider.
Annual, okay. And is that for everyone with diabetes?
That's the minimum. But for people at higher risk, maybe you already have some nerve damage or poor circulation, or you've had an ulcer before, those checks need to happen more often.
And what are they actually looking for in these checks?
Well, a really critical part is testing for nerve damage. The technical term is peripheral neuropathy.
Peripheral neuropathy.
Yeah, and the test itself can be quite simple. Often they use something called a Semmes-Weinstein test. It basically involves using a special monofilament. It looks kind of like a stiff piece of fishing line just to check sensation on your foot.
Huh. So a simple test can tell you something that important.
Exactly. It seems basic,
Hmm.
but it can pick up early nerve damage. It's a really vital piece of prevention.
That's good to know. What about the day-to-day stuff? Things people can do themselves.
Oh, absolutely. Education is huge here. Patients, families, everyone needs to understand proper daily foot care. And, for those high-risk folks we mentioned, serious neuropathy, maybe foot deformities, or if they've had a previous amputation, custom therapeutic footwear is strongly recommended.
Therapeutic footwear, like special shoes.
Precisely. They're designed to protect against pressure points. Think of them almost like a shield for your feet. And of course, probably the most important thing underpinning all of this is keeping your blood sugar under control.
Right, the glycemic control.
Yes, maintaining adequate glycemic control. Aiming for a hemoglobin A1C, that's the test measuring your average blood sugar over a few months. Keeping that below 7% significantly lowers the risk of ulcers and infections. It's like maintaining a healthy foundation for a house. You need that strong base.
That's a great way to put it, building that long-term resilience. Okay, but sometimes, despite best efforts, an ulcer might still pop up. What's the absolute first thing someone needs to do then?
The number one priority, without a doubt, is offloading, taking all the pressure off that wound.
Offloading, so just staying off your feet.
Essentially, yes, but often more actively than that. For ulcers on the bottom of the foot, things like a total contact cast or maybe a specialized irremovable fixed ankle walking boot are highly recommended. It forces the wound to rest so it can heal. It's a bit like resting a broken bone. You wouldn't walk on it, right?
Makes sense.
And here's something really important about offloading. We know it's critical, but sometimes it's underestimated just how critical. Even short periods of walking on an ulcer can set back healing significantly. So that strict offloading, it's not just a suggestion, it's really make or break.
Wow, okay, so offloading is step one.
Yeah.
What about treating the wound itself?
Frequent evaluation is key. Checking it, every 1 to 4 weeks usually to see if it's getting smaller, if it's healing properly. You want to maintain a moist wound environment with the right dressings. And regular removal of any dead tissue or thick callus around the wound, that's called sharp debridement. That's fundamental too.
Sharp debridement, okay. So, consistent care and watching it closely. But what if? What if it's just not healing? You're doing the offloading, the dressings, but it's been weeks and it's not getting much better.
That's a really important point. If an ulcer hasn't shown significant improvement, let's say at least a 50% reduction in size after a good 4 weeks of standard care, then it's definitely time to talk about other options. These are often called adjunctive therapies, advanced treatments.
Adjunctive therapies? Like what?
Well, things like negative pressure wound therapy. That uses a sort of gentle vacuum to help pull the wound edges together. Or biologics. These can include special materials, sometimes even products with living cells, designed to really kickstart that tissue growth.
Okay, so there are more advanced options if needed. We've talked about prevention, about treating an ulcer, but there's another piece, right? Circulation.
Absolutely crucial. Peripheral arterial disease, or PAD. That's where the blood flow down to the legs and feet gets restricted. It's very common with diabetes, and it massively impacts how well a wound can heal and, frankly, the risk of amputation.
So how do you know if that's an issue?
Your care team will check your circulation, often with pretty simple tests, actually, like the ankle brachial index or ABI, and measuring pressures in your toes. And if PAD is found in someone with a diabetic foot ulcer, restoring that blood flow through a process called revascularization.
Revascularization.
Right. That could mean surgery, like a bypass, or maybe a less invasive procedure. But getting that blood flowing again is often essential for saving the limb. It's a very personalized decision, though, made with the whole team.
That really brings home the team aspect, doesn't it?
It really does. Managing diabetic foot isn't a solo effort. It takes a multidisciplinary team, different specialists all working together. That truly gives you the best shot at a good outcome.
Okay, so if we were to boil this all down, what's the main thing you want our listener to take away from this deep dive?
I think it's that your understanding, your active involvement, it's incredibly powerful. Don't ever hesitate to ask questions. Ask your healthcare team about your specific risks. Ask about prevention, about offloading, about wound care, and definitely ask about your circulation status. Being informed is, well, it's your best tool.
That's great advice. And maybe here's a final thought for you to consider. Think about how taking these insights on board, really becoming an informed partner in your own care, how that shifts things. It changes your health journey from something that just happens to you into an active path you're walking towards wellness, towards really genuine empowerment.